We interviewed, as I said, patients, but also insurance companies and healthcare systems to have their perspectives represented. Some verbatims from research. System's too complicated for me to change. Our system is completely insane, and I hope it collapses soon. So a new, more sensible system might arise from the ashes. No one could tell me what the procedure would cost, zero transparency. 52% of respondents didn't do anything prior to their visit to research cost. And 61% of respondents rated their medical bills as confusing or very confusing. 46% said their actions didn't clear up their frustration with their bill. 56% said they're hesitant about seeking additional medical care. So I told the provider and the insurer about the error. It took 2 months to resolve. I should charge for my time. I finally gave up and paid the bills, having no idea what they were for. And patients don't want separate bills from hospitals, nursing, doctors. We want one statement that shows everything we owe for that service. Again, in the transformational approach, maybe there's no EOB and no bill. Maybe it's one unified financial statement as well. So finally, top concerns: too much communication, hard to understand. Patients don't know what they don't know. They're feeling around in the dark. They may have questions. Are they the right questions? Am I missing something? Am I paying a bill I shouldn't pay? Are there more bills coming? I don't know. Terminology, the timing of everything, planning out their finances. If this is one bill of many, am I preparing myself financially? And then finally, trust, which we know is a big issue. So part of the participant packet was this research report, but also a diagram of the ecosystem. We want to identify all the pieces and parts that make up the ecosystem of the medical billing experience, from clinical to insurance company to third party to pharmacy. We also mapped an example patient journey to show how they flow through this ecosystem and what can happen as an example. We also showed bills and benefit statements so people could get a sense for what things look like now, and provided guidelines, some of which came from this group here. So resources on human-centered design, on health literacy, a checklist, things like that. So we can't wait to see the outcomes of this challenge, and maybe I'll come next year and present what happened. Thank you so much.
Again? Can you hear me? Okay. Thank you. Good afternoon. My name is Renee Bogard. I am with the National Library of Medicine, which is part of the National Institutes of Health in Bethesda, Maryland. And I'm happy to be here with you today to talk to you about the role of libraries, their outreach and education role in providing ACA information and health information to the public. So first of all, I want to start off with an overview of the National Network of Libraries of Medicine, because each one of you potentially in this room is part of an organization which is part of the National Network of Libraries of Medicine, or should be part of the National Network. The National Network is an organization which has over 6,400 members, consists of academic health sciences libraries, hospital libraries, academic libraries, community college libraries, lots of different types of libraries, as well as community-based and faith-based organizations which have a mission to provide health information. The mission of the National Network of Libraries of Medicine is to provide access to all health professionals in the U.S. as well as to the public so that they can make informed decisions about their health. So what we really do is provide access through outreach and training, ensuring that everybody in the U.S. has access to quality health information. The mission of the National Network of Libraries of Medicine, and what I'm going to describe today, helps to support the National Library of Medicine's, one of their long-range goals, which is to provide access to trusted information services that promote health literacy and the reduction of health disparities worldwide. The National Network of Libraries of Medicine is administered by 8 regional medical libraries, which you see here on the map. This is under a cooperative agreement with the National Library of Medicine, and I just want to point these out so that you'll know where your regional medical library is located if you're not familiar. The first is the Middle Atlantic region. I guess this is a pointer here. The Middle Atlantic region, these are all, each one of the regional medical libraries is located in an academic health sciences library. So University of Pittsburgh Health Sciences Library hosts the Middle Atlantic region. The Southeastern Atlantic region is part of the University of Maryland Health Sciences and Human Services Library in Baltimore. Greater Midwest region is University of Iowa Health Sciences Library, Iowa City, Iowa. The Mid-Continental region is located at the University of Utah Health Sciences Library in Salt Lake City. The South Central region is located at the University of North Texas Health Sciences Library in Fort Worth. The Pacific Northwest Regional Library is located at the University of Washington Health Sciences Library in Seattle. The Pacific Southwest region is located at the UCLA Biomedical Library in Los Angeles. And finally, we have the 8th region, which is the New England region, located at the University of Massachusetts Health Sciences Library in Worcester. So hopefully you've been able to identify your regional medical library. In addition to administering the Regional Medical Library Program, each one of the regional medical libraries support sharing, curating, and annotating biomedical big data. In addition to the regional medical libraries, we have 5 national offices, and those offices coordinate evaluation, training, information access for state public health departments. The National Network of Libraries of Medicine's website, which is down here at the bottom, the URL, nnlm.gov, and the National Library of Medicine's interlibrary loan and referral system called DocLine. So as part of the outreach mission, each regional medical library develops programs and services to make quality health information available and accessible to health professionals, the public health workforce, and the public within its region. This is accomplished through grants they make to network members, training, and exhibits at health fairs and conferences. A 2011 Institute of Museum and Library Services study showed an estimated 37% of library computer users, that's approximately 28 million people each year, use the computers in public libraries and seek assistance from public librarians for information on medical conditions, finding healthcare providers, and wellness. Public libraries are present in almost every community and in general are perceived as trustworthy and helpful. As providers of internet access for people who lack internet connections at home, it was reasonable to anticipate that individuals would turn to public libraries for information on obtaining health insurance at the start of the open enrollment in October 2013. So I want to talk to you a little bit and describe the national collaboration which sort of kicked off this movement of libraries getting involved in providing ACA information. There was a national collaboration between the Centers for Medicare and Medicaid, the Institute of Museum and Library Sciences, OCLC's Web Junction, and the National Network of Libraries of Medicine. They collaborated to provide public library staff with the online resources and community contacts they would need to respond to questions regarding health insurance options and health-related questions. A panel session with representatives from the 4 collaborators presented libraries and health insurance preparing for October 1 at the American Library Association conference in June 2013, and this included a breakout session where they met with librarians to find out exactly what tools, what information they would need in anticipation of receiving questions from the public regarding health insurance enrollment. So a little bit about the individual roles of these partners in the collaboration. The Centers for Medicare and Medicaid Services and the Institute of Museum and Library Services led this collaboration. The CMS developed materials and training for health navigators and enrollment information for the public on healthcare.gov. Through a grant with the Institution of Museum and Library Services, OCLC's Web Junction developed a Health Happens in Libraries webinar series, and this session that was presented at the ALA conference was repeated in July 2013 for libraries across the U.S. Web Junction continued to host ACA-related webinars and also developed information for public libraries on how they could prepare to meet the community needs regarding the Affordable Care Act. The National Network of Libraries of Medicine had a history of collaborating with public libraries and community-based organizations to provide access to quality health information for the public. The 8 regional medical libraries, as I showed in the previous map, started off by contacting each one of the state libraries in their region to offer training to public libraries on ACA materials and to work with them to train library staff on locating quality health information that would come in as a result of individuals coming through the library for health information, health insurance information. Some of the resources that they focused on were the National Library of Medicine's Medline Plus and NIH's NIH Senior Health. I just want to say that many of the courses, I haven't stated this explicitly, but many of the courses that are developed by the National Network of Libraries of Medicine and the regional medical library staffs include a component which addresses health literacy. They teach these courses not only to healthcare professionals, but also to public library staff, health sciences library staff, so that they have an understanding of when consumers or when patients come in, what they are actually facing, and their understanding or lack of understanding, so that they can make it a better experience. Each one of the regional medical libraries developed a web page which linked users to ACA information, including state-specific information. Many of the regional medical libraries held webinars for their network members to update them on the latest ACA information available. Anyone could attend, but these webinars were specifically geared toward the public libraries. One region invited certified enrollment counselors and health navigators from each of the states in their region to present on a webinar. This allowed attendees to understand how and where enrollment would be conducted in their state. And we can't forget social media. A lot of this information was put out on the blogs of each of the regional medical libraries, the Facebook accounts, as well as Twitter. So a couple of items to note if you're thinking about, gosh, I wonder if my public library has done this, can I partner with them? Just be cautious that not all libraries operated at the same level. It was totally up to them. They served their community. They knew what resources they had available. So they could tailor the level of service they provided, both in response to health insurance information as well as health information based upon their local need and access to resources. And again, all of these resources that I'm describing today and telling you about, they were geared toward the public libraries, but anyone could register or attend these webinars or have access to the materials. And that is still true today. So I think to better help you understand some of the really interesting and collaboratory things that came out of this initiative. I want to give you some idea of some of the actual projects and activities that came out of promoting ACA with the libraries. As I mentioned earlier, network members can apply for funding to do outreach and education in their communities. And some of the network members applied for the funding and included promoting ACA with their public libraries or with communities, working with navigators, that sort of thing. So here's just a cross-section of some of the interesting projects that occurred as a result of funding. The University of Iowa Library in Iowa City held approximately 12 courses to get their public librarians in surrounding counties familiar with what was happening with ACA. The course was entitled Public Library Reference in the Affordable Care Act, Helping Your Patrons Navigate the ACA. The California State Library and the Pacific Southwest Regional Medical Library collaborated on a toolkit for public librarians throughout the state of California entitled Finding Health and Wellness at the Library, a Consumer Health Toolkit for Library Staff. And this is what it looks like. I have a link at the end of my presentation. You can check it out. The East Brunswick, New Jersey Public Library participated in a segment on a local cable television program to promote how the library was supporting the Affordable Care Act, and there were over 8,000 viewers of that particular broadcast. The Middle Atlantic region out of Pittsburgh partnered with Upstate Health Sciences Library in Syracuse to offer a symposium for librarians, the Affordable Care Act, Access to Care, Libraries Making a Difference. The Gallatin County Detention Center in Bozeman, Montana received funding from the Pacific Northwest Regional Medical Library to promote health insurance and enrollment literacy with inmates. And through this grant, they worked with inmates who were in for at least 10 days and provided them with the education they needed once they were released to go out and who they could work with in their communities to obtain health insurance. So that's an idea of a few of the projects that were implemented as a result of some of the funding that was obtained from the regional medical libraries. And I also want to mention that some of the public librarians, now this was not across the U.S., but some of the public librarians actually became they became navigators. So it really varied from what services the public librarians offered. So here is a selection of resources that were developed by the regional medical libraries for their education and training efforts throughout the initiative. In addition, I have the link to the toolkit, which you will find right here, and we also have a copy of an article that describes what the Middle Atlantic region did in contacting their state libraries and their public libraries. So in closing, I just want to say that libraries did have a role in promoting the Affordable Care Act. They've provided the public with information needed to obtain health insurance, and in some cases, they've provided the technological means for obtaining health insurance. And they have also provided access to quality health information for those individuals who have come in regarding health care issues. So for those of you who are seeking a potential partner for outreach and education, you might want to think about your public library or potentially contacting your regional medical library to assist you with that facet of the work that you're doing. Thank you.
So thank you all very much. Very informative. We really just heard our multiple successful efforts to really assure health insurance literacy, and not only health insurance literacy, but beyond. This was just beyond health insurance literacy, which was excellent, and varied consumers of healthcare. So we appreciate it, and thank you very, very much. We have time to open this up for discussion, and we'll start with the roundtable members first. Winston.
Winston Wong, a member of the Roundtable. So I was very intrigued by the MadPow presentation, as well as the folks from Consumer Checkbook. And Young and Invincibles. Because I think of, what's the opposite of Young and Invincibles? Old and decrepit, right? And I wonder... Yes. Well, the question I have, though, is I wonder if, are we trying to sell the same product to the old and decrepit to the young and invincible? Because if we are, I think that might be a losing proposition. And I wondered if there had, among all these folks that I mentioned, if there had been some intentional thinking about the vernacular that resonates with the remaining folks that still are on the sidelines in terms of the marketplaces, okay? Which, as I understood, were not the old and decrepit, were the more young and invincibles, or at least people that don't see themselves as old and decrepit. So the question is there room for a vernacular that really crosses over to the question of health literacy? So, for example, when we're talking to a group of people who are sitting on the sidelines, is it more attractive to talk about group purchasing or crowdsourcing as a way to frame the question of why insurance as a national imperative is important to spread risks, for example?
Good point. I mean, I think it comes down to understanding what will resonate with the population you're focusing on and customizing the experience to that extent. We always, in order to design for all, we can come up with kind of a very homogenized experience, and there's risk in that, but providing for different languages, different ages, different viewpoints, and I think somebody pointed out earlier an excellent point about what do people value, and framing the information and within the context of that is very, very important. And also, you know, what is going to persuade them? Is it social? Is it and that gets back to what they value. And you may be able to find patterns from demographic to demographic in terms of things that will resonate most.
Yeah, I would agree with that, and I would say that there isn't going to be one answer for everybody, either in terms of what we say, how we say it, or how we reach people, you know, how we get their attention. And I just think there have to be, you know, a lot of different things. But the core, you know, the core things that relate to what I was talking about, I do think, when put in the right language, are really the core things for most people. I mean, I do think cost and provider availability, but making those things resonate as real and the things that can affect your life does require reaching in different ways and communicating in different ways.
Cindy?
Yes, my question is for Dara Taylor, and I was very interested to hear you describe how you took the sentiments that you collected from those learning meetings with the patient navigators, and you floated them up to the White House, to HHS, et cetera. I was wondering if there were any health literacy recommendations or implications, learnings from that you could share with us, because many of us operate on a national level and would love to hear what we should be hearing from the front lines.
Sure. Thanks for that question. Interesting enough, I really believe that the majority of the challenges are rooted in health literacy in terms of what is identified at the local level. These are questions such as income inconsistency and paperwork that is received from a consumer when they apply for coverage through the marketplace. They get letters and notices saying that they haven't submitted the proper documentation on their income or their eligibility status in terms of immigration, and that's giving feedback to HHS to say that the letters and documents and notices that they're sending out to consumers don't have sufficient information or do not specifically explain what type of information is still missing. And these are several notices. One consumer can get 4 different notices, and some of the notices actually say different things, but still are not completely sufficient. So when we're hearing that that's a problem across the country, because the notices are the same from the marketplace, those are the types of things that we send back up to HHS, and that's completely a health literacy piece in terms of really trying to make sure that that document has all the information that's necessary, is written in plain language so that the everyday consumer can understand it, and those are the types of examples that we're flagging for HHS. And in some cases, there actually have been changes that have been made since the start of the first open enrollment period back in the fall of 2013. And I think I have to absolutely give HHS credit. Every concern that is flagged for them, they are genuinely concerned about. And there definitely have been some changes that have happened over the course of the years, and others that I have no doubt will be continue to be addressed as we move forward.
Linda?
I don't really have a question. I just wanted to connect some dots about the medical bill challenge. And Amy, you may not know, because I think the face to you has been HHS, but I wanted you to know that behind the scenes, this group working with the HHS Working Group on Health Literacy put together criteria for health literacy that's a part of the challenge. So I think we spent like one morning here after one of the workshops developing criteria that added into what HHS was doing. In addition to that, a number of our members have been contributing to the effort. Humana, so Kim Parson is here, and I know that they helped kind of express the pain points that patients have about the medical bills. And Steve, Humana, I think, has got a couple of...
United.
Pardon me?
United.
Health group.
Sorry, Humana, Optum, and a couple of units of United are going to be competing. Ruth, I think you helped with some of the understanding some of the problems as well. So it's really been fun to be kind of swirling around in the middle of what has been a virtual process. I will just say that going forward, Michael is going to be one of the judges. And so the HHS Working Group will be screening some of these applications. So we'll get to see some of the interesting design applications as we kind of look through them to try to narrow down the 400 applications to ones that the final judges will be reviewing. So it's really been interesting for me to see how health literacy fits into this kind of human-centered design and the overlap between those two. So it's been a really fun project, and I just want to thank everybody here for helping to contribute, and Amy for Mad Pow for working with Health 2.0 and HHS for this really interesting public-private sector collaboration.
Thank you, Linda, for that.
Thank you so much for pointing that out. So many people contributed to this, whether it was stakeholder interviews at insurance companies, health systems. There were so many groups. In fact, Community Catalyst participated as well. So really, I mean, there were 20, 30 different people, organizations that contributed to it, and that's what's leading to the very exciting quality and prospect of what's going to come out of it. So thank you so much for pointing that out.
We have a little time measurement to accomplish so we can get to the next panel. So I'm going to take Michael, Ruth, and James, go on to the break, and then the next panel. And if there's time for questions to add on, we'll do that later. So Michael.
I'll just truncate
No, you
that.
you have your time.
Okay. Michael Pachola from Boston Medical Center. Recently doing some usability studies by us, 40% of the folks from my clinic in our usability studies couldn't use a mouse. So you are not on the same page. We're not on the same page at all when we think about the user interface that we're talking about that's needed and the kind of creative possibilities that need to be thought of to get past and into that space where it's actually, intuitive design is intuitive for the people for whom it's intuitive. And otherwise it's not. And so literally, so we do stuff with human-computer interactions with avatars. Sometimes the avatar comes on the screen and the patient comes in and waves at the character because the character is waving at them. And you say, no, you have to touch the screen. Really? Touch the screen? Touch the screen? And then you can get it to go. But it's not something that's, and not to mention all the other neurocognitive barriers. The boxes are too small. The person's hand moves. All these things have to get worked out. So it's nice to think about but we need to have a whole new arena of creativity. And then to just bring back the comments from the first panel this morning, which was, we need the human interaction.
So Michael, you have to invite me to make rounds with you sometime.
Just one point in that. Accessibility is hugely important, and that's language, that's disability, cognitive and otherwise, and there's a hugely important thing called universal design, and it gets lost. And so designing for extremes, so thinking about the family that has 16 kids, and thinking about the person that lives on an island and has to take a boat, and thinking about the person who has 5 chronic conditions that they're managing. So I think we tend to scope out extreme cases when we're thinking about it, but if we design for extremes, we'll actually make things better for everybody. So it's a really good point.
Ruth?
Parker, so I'm so glad Consumer Checkbook came back again 3 years later. I remember your talk before and thought it was incredible. So I wanted to ask you, looking back over the last, since you were here before, you mentioned these 4 components, key components of a good tool. I wonder, how much progress have we made on those 4? Where are we? Can you rate them for us? And where we stand on getting what it is we need in each of those 4 to actually have good information in order to create the good tool. Give us a little progress report on that. Thanks.
Yeah, thanks for asking. I was wanting to clarify that. I think there has been some progress on all those fronts. For instance, if I look at the federally facilitated marketplace tool, there is some total cost figure that you can come up with, and it doesn't loom large for you, but you can come up with it if you ask for it, and that's progress. How good that cost figure is and how much it relates to your particular circumstance, I think is still, I think it's not there yet, but at least it's on the table with regard to the provider directory. Information, actually the federal tool lets you put in names of doctors and you find out if they are, which plans they are in. A lot of better things could be done in terms of provider directories. Why don't you say something about, even about provider directories and what it would make it easier to go down that path.
Oh, there we go. So he says that because I get pretty deep and dirty with that data. As many of you know, that data still has some problems with accuracy. So, and I guess I would say it overall reflects that a great deal of that information was still designed to flow between the provider and the insurer and not as much to flow between the provider and the consumer. So I think we're still, a really potent example of that is that you can't really identify your plan in a unique way, like a serial number on your TV. You can always find the serial number on your TV. You can't find a serial number on your plan or your network. So when you go to look at ZocDoc and you go to ask if your doctor is in network, you have to I mean, I have a slide for this, but you have to figure out whether you're in the UHC Choice Plus or the UHC Choice, and whether that plan, right? I mean, we still need a little more progress there, and I think. And right, and my sense is, and maybe the insurance folks in the room can speak to this, that the identifiers that come from the regulatory bodies are not enough, that there might be more going on that needs to be available to the consumer. And then on the formulary side, we haven't talked about that, but formularies, if you think about the country adopting NPI to be able to uniquely identify a doctor, I think formularies are still marching down that path. So when we look at drugs, which we're doing, you know, it's still a little hard to relate a drug exactly to which one it is, and so more progress is needed there. I would say the fact that the healthcare.gov forced the release of provider directories was a profoundly positive step in that it changed people's expectations. You know, they sort of really started thinking, hey, I should be able to look up for a doctor, and hopefully that will kind of continue to move forward and get past the barriers that exist.
James?
I was just going to comment that it reminds me of almost a container pill bottle and a medication label. That's what's ending up in the hand of a consumer. But what it represents is so much more than that, and the medical bill really is sitting in the hand of the consumer, but represents a lot of devil in the details that we are still working on, I guess.
Good afternoon. Jay Duig, member of the Roundtable. Thank you all for your terrific presentations. I'm interested in how you're sharing learnings about your process. I thought several of you have touched on this, and Amy, I'm most familiar with it within your space of human-centered design. So looking at not just the endpoints of what's working or what worked on individual designs themselves, and then sharing them as examples for someone to go ahead and take and build on, but talk about that process of evaluation and what worked within those areas. So for, you know, really when you're talking about having 400 different designers and firms come in, and then looking at, I was looking at a bill, you can understand, you know, the ratings that'll go on and the scoring that Michael will take part in, so in choosing the winners, but also capturing that information of what went on for, okay, this is what informed the design and development process. This is what worked, because I think a major contribution that the Roundtable has made over its course is moving away from the idea that you can have a 10-point checklist and that these are the principles and that they're always applicable, but it's more the interaction between all of this parts of the user interface, the system, and also you know, the larger use environment. So how will those learnings about the process be shared?
It's an awesome point. I mean, I've learned so much today of things that I wish I knew a few years ago, and am happy that I know now, and looking at some opportunities for collaboration. But you make a good point. There's two different, well, there's many different types of design, but there's what's called research-inspired design, where you talk to folks, you understand, you know, you ask them, what do you want? What do you need? And they tell you. But just because somebody asks for a big purple button doesn't mean a big purple button is what they really need, right? So there's some translation that occurs, but there's that, and then there's genius design, which is what Steve Jobs at Apple did with the iPhone. If you ask somebody, do you need your entire music collection in your pocket, they'd look at you like you were crazy. No, I have CDs, I have records, what are you talking about? So there's the two different methods. Now, the winning entry may have been inspired through research to come up with kind of a genius approach, or they may have very meticulously figured out what different folks need, find the patterns, and kind of go from there. But you make a good point, because when we point out who won and post those winning designs, there will be a lot of learnings that could be lost. And so what we will do is publish patterns and findings in what we learned combing through that sea of responses, so we can get some greater insight from it. But one thing we'd like to do too is kind of pull together information and resources on how to design the best plan selection tools like you guys are working on. What would the best experience be like, or what are all of the resources available? Because like I said, I'm just finding out about stuff today, and the insurance companies that I work with, I'm not sure that they're aware of this either. So it's a good point.
Jay, thank you for that point. So thank you very much. We will take, thanks very much, everybody, once again. We will take a 15-minute break and then come back for the last panel, which will be moderated by Ruth Parker.